Thank you. And I want to thank Boulder Community Health for giving me this opportunity to speak again. I've given this lecture a few times now and keep adding new material. So hopefully if someone in the audience has heard this before, they will get some new information as well. And the focus of tonight's discussion is so that everyone gets a general understanding of different types of varicose veins and also how to treat them, what are the treatment options, what are some of the symptoms, and what are some of the health risks that could potentially come from varicosities. So we're not talking just cosmetic concerns, we're focusing on medical concerns. The cosmesis, of course, is also, I'm sure, on everyone's mind, and if you're going to get treatment for varicose veins, we might as well get both benefits. So I will also talk a little bit about what we do as a comprehensive treatment package for varicosities. There are many different types of varicose veins. For most part, I think when people think about varicose veins, they think of the railroads, as grandchildren will call them, on grandma's legs or mom and dad's legs, the ropey varicose veins, the bulging veins, veins that are finger size, veins that when you walk down the street, people look at your legs and go, "Ooh, what happened to your leg?" They can come in all sizes and shapes, and they can come in all different locations. And I won't go into details on what causes the various locations, because that is something that is very technical, but they can derive from many different veins in our legs. Let's first talk about telangiectasias. Those are they're smaller than the ropey varicose veins that you've seen on the previous slide, but they are the purple raised clusters that we see in various parts of our legs. They can be back of the calf, they could be feet, ankle, thigh, they could be clustered like this, or they could be spread out. When they are spread out, patients have them all over the place, and they look like streaky purple-blue veins. Many people who come to me for treatment of ropey varicose veins naturally would like these to be taken care of as well. And fortunately, they're all the same process. So in the process of treating ropey varicose veins, many times these diminish quite a bit, and then we chase after the ones that don't go away at a later episode. And I'm sure we've all heard the term spider veins. So basically, when you have different terminologies of varicose veins, such as actual varicose veins, telangiectasias, and spider veins, we're mainly differentiating them by size of the veins. So varicose veins, by definition, are greater than 3 millimeters in size. Therefore, they look like large ropes. Telangiectasias are about a millimeter and a half each. And then spider veins in general are much less than a millimeter in size each. And they can, again, be anywhere in our legs and relate to part of the same pathologic and physiologic process as any other varicosities. When we talk about telangiectasias and spider veins, we mainly talk about cosmesis. When we talk about ropey varicose veins, as you will see in this talk later, they can become very medically problematic. Okay, so that's what we just briefly discovered. And we do also see lots of patients who come in complaining of painful legs, heavy legs, cramping, restlessness, and they don't have externally visible anything. whether it's ropey varicose veins or telangiectasias or spider veins, or they have some spider veins and telangiectasias, but they really don't have the ropey varicose veins. And their doctors would like to refer them to at least look at the veins underneath that you cannot visibly see by the eye by ultrasound and see, are those potentially problematic, but they just haven't popped out yet. So we definitely have those situations as well. Okay, what causes varicose veins? Varicose veins affect many women and many men, and it definitely increases in a percentage by age and also by body habitus. It is combined with congenital predisposition as well as environmental. And we probably have all heard my grandma had varicose veins or my mom has bad varicose veins and I'm getting them as well. So family history definitely plays a very strong role. If you have family predisposition and then you have a job that you're on your feet all day, you're a mailman, you're a mail carrier, you are on your feet in the operating room all day. Then you add environmental factors to the genetic predisposition, and that significantly increases the risk and the rate of developing varicosities, especially symptomatic varicosities. And we will again talk about how they can be medically problematic. A lot of the common symptoms that we see with varicose veins are heaviness, achiness, my legs are tired at the end of the day, my ankles swell up, I have restlessness at nighttime, I have cramps that wake me up at nighttime, I feel better when I go home and hang my feet upside down on the wall. These are very common things that we hear. And when it comes to medically problematic varicosities, as varicose veins progress to worsening severity, the skin starts to change. The skin becomes brown, hyperpigmented, in other words, and that can eventually evolve to dermatitis, cellulitis, which is infection with the skin, and with enough swelling and skin change, eventually ulceration and breakdown of skin. That is when infection can get into the muscles and the bones and cause significant medical risks. In addition, even in the absence of dermatitis and ulceration, when varicosities become large enough, the blood pooling or stasis of blood is severe enough such that people are predisposed or at risk for developing blood clots. And blood clots in the varicose veins can go into the deep system, subsequently into the lungs, and that in turn can be life-threatening. So there are many medical reasons to treat varicose veins. Some of the worst conditions that I have seen, and I want to caution you for having a strong stomach in looking at some of these pictures. These are some of the eventual, worst case scenarios for varicosities. So this patient, for example, has, as you can see, ropey varicose veins up in the inner thigh where the skin actually is pretty normal in color. Then heading down towards the calf, we have the dermatitic changes. We have the hyperpigmentation, the redness, the purple discoloration, brown discoloration, and also a patch of early developing ulcer. If you were to able to palpate the skin is very hard because oftentimes inflammation builds calcium in the skin, so the skin becomes rock hard, and rock hard skin is not elastic. So when it gets injured and gets bumped or bruised, that injury doesn't recoil back and it doesn't heal, and that is what eventually develop into ulcers. Another patient with dermatitis and ulcer, the blue patch is a wound care dressing material that is applied to the ulcer. If that were to be removed, you will see as you can imagine, underneath tissue. Here is a leg with underneath tissue shown. These ulcers in general, they're large, but they're shallow. But you can definitely have very small ulcers that are much deeper than what is shown on these pictures. Here's a patient with both extremity bad ulceration. Okay, let's talk about some of the anatomy that eventually contribute to varicosities. We have in our legs, and everyone has this, both deep and superficial system. The deep system is what we cannot do any procedure on. We cannot fix them. We can't replace the valves when the valves are broken. So it is very important that we try to keep our deep system as normal as possible. Varicose veins, fortunately, most of the time come from the superficial system, which we can get rid of and not even miss them, because those are some of the veins, when they're normal, that are harvested for heart surgeries, for bypass surgeries. So we don't need them. We definitely need our deep system. Unfortunately though, when you have varicose veins originating from the superficial system, oftentimes they cannot be used for bypass surgeries depending on size and degree of valve incompetence. So that is a blessing in disguise, I suppose you could say, because if you have bad varicose veins and we need to get rid of the superficial system, it's not like they can be used in the future anyways. So let's talk about blood flow in the superficial system. Why does it become abnormal? How does it become abnormal that then eventually develop into varicosities? Under normal circumstances, we have valves in all of our veins. Those valves are shaped like a teepee. So when blood goes up, the valve shapes prevent them from coming down, prevent blood from coming down. So therefore, these valves protect our legs from pooling of blood due to gravity and standing on our feet all day. When the valves are spread apart and broken, meaning they don't touch each other anymore, then they're sort of flopping in the breeze. And when they're flopping in the breeze, then blood can just go up and down in between them, and gravity always wins. So the longer we stay on our feet, the more blood pulls down the legs. And when blood pulls down those veins, they distend, they give over time, and they no longer are the healthy small veins that they should be. They become the ropey varicose veins that we see. This is a video, I believe, that will be helpful to dynamically show everyone what exactly the valvular physiology does.
This animation shows how varicose veins form. Varicose veins are swollen veins that are a blue or purple color. They show through the skin, usually on the legs and feet. Click the navigation arrows below the animation screen to play, pause, rewind, or fast forward the animation. The superficial veins lie below the surface of the skin. The deep veins pass through the deep tissues of the legs. They transport blood from the legs and feet back up towards the heart. The superficial and deep veins are connected by perforator veins. Here we show the position of the deep veins, superficial veins, and perforator veins in the leg. The deep veins run between the muscles of the legs. Contractions of these muscles, when you move your legs and ankles, help to squeeze the blood back up towards your heart. Veins also have valves that prevent the blood from flowing back towards your feet. Here we show a valve and the muscles around the vein. Varicose veins are thought to develop when the valves don't close properly. Here we show a valve in a superficial leg vein. If the valves don't work properly, the blood is able to flow backwards. Blood pools in the vein, causing the vein to stretch. This is called a varicose vein. Here we show a vein that has become varicose. Here we show a varicose vein in the lower leg.
Okay. Let's go back to the slide. Okay, so I hope that made a lot of sense for people. I think a picture is worth 1,000 words, or in this case, a video is worth 1,000 words. And you can understand from that video, when you have all that red blood cell pooling in a large diameter vein, how that could become stasis and stagnation becomes blood clot. Okay. For those of you who, and I see a lot of patients who come very frustrated with this, is that they have had symptoms, they have had varicosities, and they have definitely had worsening symptoms, but yet they don't know where to go and what to do about it. There's probably safe to say a general lack of public knowledge as far as for both the general public as well as physicians on what should we do about varicose veins. Because historically, this was thought to be just cosmetic. And it has become very evident. We spend a lot of money every year, billions of dollars, treating wound care patients, ulcerating patients, that it's gone to a point where insurances are recognizing this is not cosmetic. And I think slowly over time, people are getting educated and physicians are getting educated to know when to refer. So if you hear, you gotta live with it, sorry, there's nothing I can do for you, they are just cosmetic and just put your feet up every day, know that if your symptoms are bad enough, there likely may be something that can be done to help you. What are some of the self-care measurements that people can do every day at home? Exercise. Exercise is great for us in general, and in this particular setting, if you can imagine a vein that is not as strong as it should be. If you were to exercise and squeeze the calf, then the calf muscles help support the blood that is in the vein and actually squeeze the blood back up when the vein itself isn't doing as good of a job as it should. Of course, there's a balance. If you are on your feet too much, you're exercising all the time, that also can pull blood down to the feet if you actually have bad varicosities. So exercise and calf, walking and maintaining a fit status is in general healthy for us for multiple reasons, as we know, but it doesn't fix bad varicosities. It can help milder symptoms. Elevation, of course, that's again physiology and gravity, draining blood and helping the blood to get back to your heart. And avoiding long time of standing or sitting. And sitting also does the same thing because of gravity, and also we're bending our legs in various positions, whether it's the hips or the knees, and sometimes that does, in a way, hinder blood flow back to your heart and into your main system if you were sitting for a prolonged period of time. So it is helpful to get up and walk around every once in a while. When you're on a flight, a long flight especially, if you have a sitting job or a desk job, to sometimes get up and walk in place, those are all very helpful. Compression, I have to say, is your #1 friend, even if you don't have varicose veins. And how many times have we heard, my legs just ache, they're so tired at the end of the day, and they're swollen, they feel heavy, but yet if you look at your legs, you know the difference, but other people can't really tell the difference. And if I were to do an ultrasound on you, there are no bad broken valves, and you don't have externally visible varicose veins, but you feel it, you feel the heaviness. And that is, again, because of the effect of gravity. Compression will make you feel supported, it will help circulation in general, and at the end of the day, you feel much more energetic. Legs aren't as tired, and they don't feel as swollen. So I wear my compressions as much as I can. Hot summer days, when you're in shorts, probably not, but winter days when you're in long pants, they definitely come handy. especially well-fit compression. They are comfortable, and the myth is that they cut out circulation. And I would like to get rid of that myth at this time and say that if you have really well-fit compression, they are helpful for circulation. In general, we recommend a minimum of 18 millimeter mercury compression. To start with, if you are not used to them, you could try the 15 millimeter and then gradually work your way up to 20 to 30 millimeter. Many patients are in the 30 to 40 millimeter mercury compression level. They are tight and they are hard to get on. Many of our ulcer patients have custom-made compression that are much higher than 40 millimeter mercury compression. And some other self-care measures, there are some people that believe in anti-inflammatory diet, and horse chestnut is an herb that is believed to help with swelling, tissue swelling, and edema. Butcher's broom is another one. There are various things that people can try. Just like any other herbal treatments, they don't interfere with any other medical treatment that you could potentially get, but they also have variable results on individuals. Okay, we're gonna move forward into what are some of the treatment options. We have a wonderful wound care clinic here at Boulder Community Hospital who see our patients with dermatitis and ulcers. Historically, you have heard of sealing or foam sclerotherapy. Those are generally applied to spider veins and telangiectasias. For the larger ropey varicose veins, some people have heard the term stripping and surgical phlebectomy. Those are some of the older terms, and let's talk about what we do today. Today, we don't strip. We don't do the surgical traditional phlebectomy, which are larger incisions. They're usually about ½ an inch in size. We do what's called microphlebectomy, and I will go more into that. But for the stripping part, we now have replaced stripping with ablation procedures. There are two types of ablation procedures. One is heat-based, and one is non-heat-based. Heat-based is laser, radiofrequency ablation, and there are different types of laser and different types of radiofrequency. They are cauterizing the vein by heat from the inside. Non-heat-based ablation are basically, short of lack of better word, is injecting a glue equivalent, which does not heat up, that then congeal inside the vein and treat the varicose vein. At Boulder Community, we do the heat-based ablation treatments. We do not offer the glue-type ablation treatments, in case anyone's wondering, and there's various reasons for that. There are microfoam sclerotherapy injection that we do at the same time as the ablation therapy, and microphlebectomy if needed after all that. The first step to knowing how to treat an individual is to figure out what is the source of varicosity. And that is gonna vary for everyone. So the very first step is to do an ultrasound to figure out where are these varicose veins come from. Why do we do ultrasound? So ultrasound actually tells you valvular incompetence and degree of valvular incompetence in which body part or which one of the varicose veins or superficial vein system that is contributing to the varicose veins in that particular patient. So I will show you an ultrasound video that I think also shows it very clearly what exactly we're looking at on ultrasound. This ultrasound doesn't come with any volume or speak, so I will just show you. This is flow. The orange is in the correct direction, and the blue is in the incorrect direction. So orange goes up, blue is going back down. So in this particular incident, you can see where an individual has a certain amount of time where the vein is spending time in the blue color, which means the amount of time that the blood is actually refluxing back down rather than going up. So we are actually looking specifically for this type of anatomy when we are doing an ultrasound. Normal veins with normal valves have reflux less than 0.5 seconds. Anytime patients have reflux greater than 0.5 seconds, that begins the development of varicosities. And we have seen patients who never stop refluxing. So it ranges from 1 second of reflux to 2 seconds to 3 seconds to you run out of screen time to measure how many seconds this patient is refluxing. And our screen time goes up to 10 seconds. So that in turn explains severity of varicosities and also the type of symptoms that that patient presents with. So when I see a patient for an ultrasound, I look at the patient, I talk to the patient about what are your symptoms, and then I look at the ultrasound. I do the ultrasound myself. I have a sonographer who helps me document, and then I put everything together and say to myself, does this really make sense? Does the ultrasound make sense with what I'm hearing and what I'm seeing on the patient's extremity? It all needs to tie together in order for us to come with a good treatment option, and there's many different types of treatments we can do to be able to really help that patient. So the first step, if you were to come to BCH, is to schedule an ultrasound, which is also a consultation with me, and it happens usually first thing in the morning. Let me go back to slideshow here. Okay, then after the ultrasound, from that I am able to figure out what are the treatment options that are available for you, what can we do to help the symptoms, and then we do insurance authorization based off of the clinical information on that ultrasound. That gets sent to insurance, who then determines, do you have a policy that covers this particular set of procedures that I am recommending? If you do, that will be back as a letter for both you and us that it is approved. Then the interventional radiology department calls you to schedule. And when you are scheduled, it is in a operating room suite condition where you are prepped and draped in a sterile fashion. You're covered in blue, and we are masked and gowned and hatted in the operating room situation. And I have a scrub-in assistant who helps me, and so everything is done in sterile condition. There is conscious sedation, which is colonoscopy drugs, fentanyl and Versed for those who need it. I will say 99.9% of our patients do the laser ablation and the sclerotherapy, which is all done at once, without conscious sedation. If you need microphlebectomy, which is a little mini version of stripping, that might come with some sedation. Sedation might be handy. Difference is, without sedation, you can drive yourself in, drive yourself home. It's an outpatient procedure. And with sedation, you will need to have a ride and be NPO after midnight. Okay, once the vein that is abnormal is determined by the ultrasound, and you're on the table, then we put a very small laser catheter inside that vein. Then we introduce what's called a tumescent anesthesia, which is lidocaine mixed with saline and some epinephrine, and we numb up the entirety of the length of that vein to protect the tissue around the vein before we turn on the laser machine. Then the laser machine gets turned on, and the laser does the job from the inside. The cauterization essentially shuts that vein down. So therefore, the valves that are broken are no longer in play, and they don't stay open, and they don't pull blood down to the lower extremity. So in essence, we're shutting off the floodgate. And I wish I can load this as a picture, but at the same time, as a video, but unfortunately it didn't load, but I'll just describe the picture here. At the same time, after laser ablation, what I do is I use ultrasound to find little tiny veins. And this is a very skinny 25 gauge needle, which is the smallest needle that we have for anesthesia, for anesthetics that provides lidocaine anesthesia. And I use this little needle to get into a vein that is sometimes as small as 2 millimeter. Then once I get the vein inside, or the needle inside that vein, I inject the microphone sclerosant. And if this video were able to play, I'm sorry that it can't, but you would see bubbles going not only in the tip of the needle, but it goes everywhere else. And it is amazing that one injection at one place in the setting of valvular incompetence treats several inches to 20, 30 centimeters, sometimes downstream or upstream, depending on the direction of the blood flow that the vein is contributing to. And that is how we treat veins that you cannot laser because they're too small and they are serpiginous. There's multiple channels in our legs that are all interconnected that contribute to varicose veins. And where do I inject is determined by the ultrasound. Okay, so what about these large ropes? Today, what we do, first step is laser and sclerotherapy, which we've already just talked about. What if you still have these ropey varicose veins left after laser and sclerotherapy? Most of the time, they're much less in extent compared to what you're seeing on this picture, because the laser and the sclerotherapy have shut down the floodgate and have really helped shrink down these veins. But as we already talked about, veins are all interconnected in our legs. So once you shut down one main tributary, many others sometimes factor in that you cannot possibly foresee or even get to all at once. So then that is then in turn what keeps some of these veins still full and still bulgy. But we want to get rid of the cosmesis effect of these varicose veins, right? So then what we do is the second step, which is microphlebectomy. And what happens with microphlebectomy is at the day of the surgery, you're in an upright position and we map out these bulging varicosities by drawing on you. And these are some of the examples of patients with extensive residual varicosities that need to be removed. So then you're prepped on the table. These veins are drawn out in blue because once you lay flat, I don't see them bulging anymore. So I rely on my lines to tell me where I'm going to go when you are flat. And then again, anesthesia is delivered along these veins, and we actually use a small needle, get into the area, and we actually physically remove these veins. So that's why it's called a microphlebectomy, because it's no longer half-an-inch cut as the traditional phlebectomy used to be. The end result of all of these procedures is, of course, to get the symptoms better. That's number one focus, to make you feel better, help you feel better. Number two, to reduce additional future medical risks and skin changes. And number three, to look better. Okay, so let's see a little bit of pre and post before we go into the additional cosmesis stuff that we can do. So pre and post of a patient with ropey varicose veins. And these are usually about a month to 2 months after. If this patient has had just laser and sclerotherapy, we get these pictures within 2 weeks. If they've had the microphlebectomy, then there's bruising, there's some swelling that needs to be healed. So these pictures are about a month to 2 out. Okay, again, various different patients, pre and post. That's that patient that was on the table. This is 2 weeks after she had some microphlebectomy. She has some purple bruising, as you can see, on the inner thigh, but the ropey varicose veins mostly are gone, and then that bruising goes away, and we have overall happier looking leg. Okay, here's another example of a patient with very large ropey varicose veins that looks much better about a month out. Here's a patient that we treated for the purpose of ulceration. This is where this is where my job becomes so satisfying for this line of work, is because that big area of ulcer becomes a much smaller area of ulcer as the skin continues to heal. This is a couple months out of our treatment for this patient, pre and post. Okay, this is a patient who has had this amount of ulceration for 10 plus years. And he has been to many, many physicians who said, there's nothing we can do for you. And lo and behold, he had very, very bad refluxing varicosity up in his upper thigh, but he doesn't have ropey varicose veins. But the valves contributing to this location were indeed damaged. We do the treatment, and he was actually hospitalized because he was very sick. And this is from September to December. We were looking at this patient in the hospital, and you can see this patient's leg literally closing and healing in front of your eyes. It was extremely rewarding. Okay, so let's touch a little bit about the telangiectasias and spiders. What if you don't have large ropey varicose veins and you just have these purple discolorations, or you have all of them and you want to get all of them treated? The laser and the sclerotherapy that I do by ultrasound guidance mainly treat the large veins and the main sources. These little veins on the surface of the skin are caused by broken valves at the very little tiny venule at the surface of the skin. And oftentimes, they're improved from laser and sclerotherapy, but they're not gone. So then what do? Then we go back in with a different type of sclerosant and inject the leftover spider veins and telangiectasias separately just to help them to go away. And again, I have videos here, but I'll just explain. This is what that looks like. Here's a patient with residual telangiectasias that I will use a very small needle, get into the little individual veins, and inject a different kind of sclerosant compared to the microfoam that I do by ultrasound guidance. And the video would show you that these veins they will blanch out and become white immediately on the table. So then that's how you know that your injection is inside these veins. Then within about 5 minutes, they become more red. They come back and they become more red, and they stay red and kind of angry looking for a good 2 weeks, worst case scenario, 5 weeks. Then it all heals and the veins get much better. Another situation, this is the same patient. She had lots of these veins. One is at the inner knee. The first picture was behind the knee. This is at the inner knee area, and I'm just using little needle pokes to try to get as many of that as possible. As you can imagine, many times these treatments take way more than just one episode. Okay, here's the same patient at the ankle where we're now treating some spider veins. So same concept though, we put the small needle into them and we inject. And I just wanted to show, this is 5 days. 5 days out, left-sided picture is the initial, right-sided picture is 5 days out. As you can see, the amount of the telangiectasia and the blue-purple veins are better, but there is still redness, there is still bruising, and that is what's going to heal about a couple more weeks out, and then it'll look much better. And then at that point, we'll see what's left. If she wants more treatment, we will then do additional treatment and start the cycle again until she gets to a point cosmetically that she's happy. Same location, we can see that the streaky purple veins are less and better, but 5 days out, it is still red and a little bruised. There are many, many other complexities to varicosity. We just today touched on basically legs from groin down. There are veins that are from groin up in our deep abdomen and pelvis that we will not go into details today, but there are many times that there are abnormalities there. There is a completely different treatment option and methodology and different evaluation. So if you're going to take anything out of today's lecture, please remember that varicose veins are not straightforward most of the time. They are not just cosmetic. They can cause problems, and if you have symptoms and you don't know whether varicose veins could be a cause of it or valvular incompetence could be a cause of it, getting an ultrasound at a vein institute, vein clinic, Boulder Community Hospital is a great way to start. Thank you very much, and really appreciate this opportunity again.
Thank you, doctor, so much. That was very informative, and we all really appreciate your time and expertise. We have time for a few questions, and so here we go. The first is, can the valves in the vein repair on their own after they have become compromised? I'm sorry for stumbling over that. Can a vein just repair itself after getting compromised?
No. And that goes for both superficial and deep. So when you have superficial valves that are broken, we do the laser treatment, etc., to treat them. If you have deep valves that are broken, that becomes very problematic because there are no surgeries today to replace them, and they don't get fixed by themselves.
Let's see. I'm so sorry. Is varicose vein treatment covered by insurance? I think you covered that, but is it covered by Medicare?
Yes, it is. Medicare, prior to January of this year, did not require pre-authorization. And starting January of this year, Medicare is requiring pre-authorization. So we are pre-authorizing Medicare patients.
Great, great. What is the cost for this treatment if one does not have insurance? Can you give a range on that?
Yes, there is a very reasonable and competitive self-pay rate at Boulder Community. I don't know if anybody has asked around in vein clinics. I did when I was trying to figure out what is reasonable. So the comprehensive cost for everything, that's laser, sclerotherapy, visits afterwards, and microphlebectomy with sedation and recovery. So those are multiple visits. The comprehensive is $5,000 per leg. What I'm often hearing is it's $5,000 for just laser treatment at various vein centers. I've heard a price as high as $12,000 per leg. So you'd have to call and ask around. And then there's breakdown. If you don't need all of the comprehensive treatment, there's breakdown of laser, sclero, and phlebectomy.
This patient, let's see, what is your wait time at this time to get an appointment?
I'm sorry, what is what?
What is the wait time at this time with?
To make an appointment?
Yeah,
so
to get an appointment.
There's a phone number to call, and so I believe, well, I don't know the answer to that. There's a scheduler and a scheduling office that handles all these calls, and we just book them first come, first serve. I know May is booked for both ultrasounds and procedures. So I have ultrasound days, and then I have procedure days. And then I think June, we're still working on.
What is the agent that you're using for the injection? What is that made of?
So there's two different kinds of sclerotherapy, as we talked about. One is the deeper ultrasound guided. That is SDS, Sotradecol. And we foam it up, so it's called microfoam sclerotherapy. The one that we use that's not ultrasound guided, that's for the telangiectasias and the spider veins, that is a sclera. And it's sclera with an A in front of it. So there's a huge long, it's polydolcanol, I don't know if anyone's heard of it, but it's a long name, and there are two different kinds of sclerosants. We don't use saline, if anyone's wondering.
And is it painful? Is this a painful procedure?
Well, the laser, so it's needle pokes. Lots of needle pokes to numb up the skin. Those are usually, numb up the deeper tissue around the vein. Those are not as bothersome to patients because they're deeper. Interestingly, it's the little spider and telangiectasia injections, and even though the needle is a 30 gauge, it's tiny, I think the little needles really do bite. So I've had patients who aren't bothered by them at all, and I've had patients who, after a couple of injections, couldn't do anymore. It's so variable for everyone.
Do you use any sort of
like an anesthetic,
numbing or some
like
sort
a skin anesthetic?
Yeah.
What you want to do, so we can use a spray, but there's a trick to that because if you cover it up too much, then you don't see the veins. And you want to get your needle into the veins. And it's very quick and it's very delicate. So you definitely don't want to extravasate. So there's a balance.
I think you covered this, but can you go over again, what is the recovery time and when can you return to normal activity?
Right. So for outpatient laser and sclero, you see me for ultrasound, that's day one. You have a prescription for a pair of stockings that you have to have the time of your surgery. You bring the stocking with the day of your surgery, and you put your stockings on after surgery, and you walk out of the hospital. In general, so you can resume regular activity other than heavy lifting greater than 20 pounds, 30 pounds for 5 days. So we prefer no strenuous activity like biking, hiking, skiing, swimming, etc., and no heavy lifting for 5 days. The stockings need to stay on when you're awake, not when you're asleep, for a minimum of 5 days, but the more you wear them, the better. The faster that'll help you heal. But there's really no, other than the exercise and the heavy lifting, there's no downtime per se. You can go about your everyday, daily other things and go back to work, etc.
Does a treatment ever need to be repeated?
It depends, right? So if you have the spider veins, multiple episodes sometimes are needed to treat them. If you have very large, ropey varicose veins, so I've done thousands of these now, and I think I can count in one handful of patients that I've had to laser 2 to 3 times because their veins were so big to begin with, it just doesn't want to stay closed. You laser it. I actually just had this one patient that went to someone else who lasered it twice, came to me. I lasered it the 3rd time and had to laser it the 4th time before it finally closed. But we didn't want it to win, so we got it. So sometimes repeat treatment is needed if the vein just doesn't want to stay shut. But that's very rare.
Do varicose veins contribute to cold extremities?
When I think of cold legs, I think in general arterial problems rather than venous problems. So I think when we're doing these ultrasounds, we take a feel for your pulses to get an idea of, do you have arterial problems, and that the skin changes and et cetera are really not vein issues. So we kind of think of all of that. So I think in general, no.
What are the risks of these procedures? Can they cause clots?
Well, we are making blood clot, right? We're making blood clot, but the amount of blood or the type of blood clot that is created in a varicose vein caused by sclerotherapy or laser is completely different than, and we now know that, completely different than the amount of clot or the type of clot that is created on your own spontaneously. So we have never had a case of a DVT. I personally have not, I have to say. I have never had a case of PE, pulmonary embolism, as a result of laser ablation. Fortunately, knock on wood, I haven't had a case of cellulitis or infection, but anytime you stick a needle into a patient, there's always a chance of infection, bleeding. Bleeding is one of the issues we do run into in people who have had the stripping or the microphlebectomy procedure, but that's usually in recovery room. They do it once and they're done by the time they get home. So it's not a problem to deal with after you get home. So there's a recovery process with that, which I didn't go into very detailed because we don't have time to talk about everything, but those are all talked about in detail if a patient were to come see me, and then we figure out what's available to them at the time of consultation. These are all explained.
So a viewer here wears 30 to 40 compression socks. Is it okay to go to a higher compression? I guess maybe, can you get too much compression? Okay, short answer to that is there is no such thing as too much compression. But the caveat to that is, do you actually need it? If you are tolerating 30 to 40 and you're still getting heaviness, you're still getting swelling, and you have ulcerating issues, dermatitis issues, first of all, I think a wound care clinic scenario should be helping you to manage. And in those circumstances, I think higher compression would be warranted. But if you have healthy legs and not much symptom, and you just want to go up to compression for the fun of it, I would not recommend that, because you could potentially get to the point where you're actually cutting out your own arterial blood supply. Then that creates a problem than helping. That's like wrapping an ace bandage too tight on your legs. So it really, the answer to that is, it depends on the need. It depends on the clinical presentation. After ankle surgery 10 years ago, I developed the word that starts with T that I may not be able to pronounce,
telangiectasias?
Yes, in her ankles. Now she needs knee surgery. Should I have veins taken care of before the knee surgery?
If it's just telangiectasias, I'm not sure there's a way to prevent them from developing. When a skin is cut and damaged, or for example, we bumped our leg and or fell off a horse or got kicked by a horse or something, that focal area, the traumatized area, the veins in that skin can become broken. The valves in those veins in the skin can become broken. That then predispose you to develop telangiectasias right in that spot. So if you don't have any ropey varicose vein issues or swelling issues otherwise, I would say there's probably not a whole lot that we can do to prevent telangiectasia developing. But if you have ropey varicose veins and other symptoms associated with varicosities, it definitely is a good idea to get that taken care of before knee replacement, because then you are minimizing risk of bleeding and blood clotting after the procedure.
We have time for 2 more questions. Can varicose veins cause nighttime? Here we go. Can varicose veins cause nighttime leg cramps? And if so, why don't those cramps happen during the day?
I think during the day you're walking, your calves are squeezing, and you're helping your legs and circulation moving. That's one of the theory. At nighttime, they're not moving, they're not squeezing, and your veins are swishing back and forth, and they're doing their thing, and you're feeling the cramp. And some people describe it as really weird sensations. That you're feeling that at nighttime more because of the alteration in the blood flow. But for sure, varicose veins can cause nighttime cramps.
You just mentioned cold could be arterial, not veins. How do they look different on a patient?
It's by exam. It's not a look thing. Sometimes you can differentiate by looks, but it's by physical exam. Pulses, capillary refill, other exams that we will have to do to check out the system. So unfortunately, that's not do you have blanchy toes. If you pinch your toe, does the color come back from blanching in, a second or less than 3 seconds for sure? So there's many, many things that we look at to differentiate arterial versus venous.
We have one last question, and it does have to do with Medicare. So a viewer asked, do I understand that prior to January 2021, Medicare did not require prior authorization for procedures, and after this date, you do need pre-authorization?
So basically now Medicare requires pre-auth.
Right.